Hey, good morning, good afternoon, or good evening, depending upon where on the planet you are. This is Eric Rubenstein. I am the Director of Litigation, Fraud, Waste, and Abuse Support here at Advize Health. If you've been tracking things that we've got up online, everything from our podcast to our newsletter to our LinkedIn posts, you know that we are growing by leaps and bounds here at Advize. And one of our newest acquisitions, so to speak, is Laurie McMillan, who's here with me today. Laurie comes from an extensive background. She is a registered nurse. He is also a certified professional coder and comes to us as a subject matter expert, most recently from the Southwest UPIC, and is one of only a handful of people in the country who was authorized by CMS to provide legal opinions and qualified as an expert to speak on behalf of CMS. Laurie, could you take a minute to introduce yourself? Tell us a little bit about yourself.
Oh, Eric, thank you for having me. This is a pleasure, and I'm looking forward to doing this. This is my first podcast, so just a little bit of beginner's luck there. So I have been, recently employed by a UPIC. I worked there for about 7 years, from 2014 to 2021, and before that, I came from a MAC. I also had a little bit of experience working for a Part C. So I've spent numerous years looking at records and hope to share with you a little bit of the experience that I've gained from that. And then before that, I had quite a bit of clinical experience. As you said, I'm an RN and I worked for years in cardiac care, critical care. I worked in a cath lab. I worked in a physician's office. So I have quite a bit range of clinical experience too.
Yeah, that's great. So one of the things for those of you that are watching or listening to this is that Laurie does not sit and just review medical records and identify whether or not that E&M was properly coded or not. She really is much more deeply involved in the subject matter expertise of clinical coding as it relates to the documentation. But more importantly, is that Laurie's expertise is really in the interpretation of CMS's NCDs, LCDs, and the LCAs, which really means that when some of the clients that we have here at Advize, places like the Department of Justice, come to us and say, hey, we need somebody who has this very particular expertise and can provide an opinion that is based upon both her expertise and her knowledge. That's where Laurie comes into play. So she is one of, again, a handful of people in the country who has been qualified as an expert, not just as a fraud, waste, abuse, compliance subject matter expert, but as an expert for the purposes of being able to share what CMS's position is on things versus someone coming in and interpreting what they think CMS's position is on things. And that's a very big difference. So we're super excited to have Laurie as part of the Advize team consulting with us and excited to be able to have some ongoing conversations with Laurie as part of my Retro Fraud podcast. So today we're actually going to be talking about a pretty timely topic that is very common. It is going to be something that I think a lot of providers are going to be seeing happen a lot, particularly now that CMS has unleashed everybody with respect to audits and investigations on the CMS side. As the public health emergency starts to go away, and as states open up and as the country opens up, CMS has started to, you've started to see on the UPIC side and the MAC side a lot more audits. And what you're seeing is a lot more investigations as well. Now, typically there are a couple of different levels of these. There's prepay and post-pay and then sort of investigational. And a lot of people are out there having conversations about them, and they're talking about them from the outside looking in. As those of you who follow me on LinkedIn know that I'm a retired OIG agent. I spent my career in the New York and New Jersey area doing criminal, civil, and administrative investigations. And Laurie, having come from the UPIC, we see things from a slightly different perspective. Today, I want to talk to Laurie a little bit about and get her perspective and understanding and have her really educate all of you about prepays and how they really work and the things that kind of what gets a provider on prepay and how do you get off and those dreaded error rates and what's out there and really what's the point of a prepay. So Laurie, I kind of always throw that feeder and then I just want to unleash you and let you go and sort of give an understanding to everybody about what is a prepay, how does a provider get on prepay, How do you get off a prepay? I think that's the big thing that everybody wants to know, and just sort of the point behind a prepay for the next few minutes.
Okay, well, so let's start very basic. Remember that Medicare, I'm going to specifically talk about Medicare claims, those are all filed electronically. And once you sign that provider agreement and agree to abide by certain things, one, that you're going to submit true, accurate, and honest claims to Medicare, Medicare in turn is going to pay you in a very timely manner. So most of the claims that get submitted in the system are not reviewed. However, CMS's number one priority is to make sure that claims are paid accurately, not too much, not less than they should be paid, and not more than they should pay, and that you're meeting those payment terms. So we can put you on prepay. What does that mean? When you submit that claim into the system, it's going to have an edit, stop that claim from being paid, and it's going to ask you to submit that documentation for review. Typically, you're going to get a little letter that says, in various terms, congratulations, you've been selected, you are a winner, and please submit this documentation for this service. Now, a couple of things to keep in mind. Remember, this system is electronic, so your letter may be electronic. Those claims are coming in, and you might say, well, what is hitting that? What is making that get hit off? It could be numerous things, and you may not know exactly what is hitting it off. So the system has the ability to put edits in, and when I say edit, I mean something that's going to stop that claim from moving on through the system to be paid. So it could be a specific provider. It could be a specific CPT code. It could be any numerous things, and it could be the data service. Maybe you are billed too many things on that data service. Maybe it's a diagnosis code that they're looking at. So it can be, there's several things that are listed that could trigger that. And if it is provider specific, you'll probably get a letter saying, hello, just to let you know you've been selected for prepay. If it's something broader than that, like say a CPT code, you as a provider might not know that code is going to set off an edit to hit a
Right,
prepay.
right. So when you're talking about some of these edits, we're talking about in some cases the NCCI edits, the medically unlikely edits, and then we're just talking about edits that could be in place as the result of an LCD or an NCD, where, for example, you can't bill for this code when you do that code, separate from an NCCI or an MUE edit. And then for providers, one of the things that we talk about with a lot of our clients here is analytics. I ask the provider clients that I deal with, are you looking at your utilization management reports? Because the OIG is, the UPICs are, the MACs are, commercial payers are. Are you an outlier to something? Did you not go from billing a certain procedure and then all of a sudden you've had a tectonic shift? The example I always give is if you're a general practice ophthalmologist and you bring in a retinal specialist, and maybe you never billed for a single retinal procedure, and then all of a sudden you're billing for retinal procedures, that may make you an outlier. If you're a general ophthalmologist and you don't do glaucoma, and you bring in a glaucoma specialist, and you are suddenly billing for peripheral iridotomies and YAG lasers and things of that sort, that will create an outlier, which may trigger that prepay. So it really can run the spectrum of things from traditional plan type edits all the way through to provider specific and NCD, LCD.
Right. And one of the things that I would talk about, when your person who is inputting that information into the claim system and they're filling in all those blanks, you want to make sure that that person is knowledgeable about the information that they are putting in and that they're not just filling a blank in to make it filled in. Because all of that information, as you talk about data analytics, there's a lot of people and companies that are looking at that data and analyzing. And if you're putting in some erroneous information, you're likely to get selected because the system is going to say, why is this happening? Why is this happening? So be accurate about what you're putting into the claim system and make sure that you have documentation to support that information you're putting in so that if you do get selected, you're going to have information to back it up.
Right. So let's talk a little bit about, so we've talked about what potentially gets you onto a prepay. Let's talk about people that are on providers that then get stuck onto a prepay because it's an individual provider. What sort of, when we're talking about error rates and sort of we'll call it forced education, right? Because the provider gets put on prepay oftentimes because they've done something that's aberrant and that has caused the program to say, hey, we're not going to pay you for this until we have vetted it out. What is the goal of a prepay?
Well, so there can be several goals. One is, corrective action leading to education. So, depending on, what the situation is, what you're doing is if there's findings that, they say this needs some education, you are educated, and then they can go back in maybe 6 months later. And kind of take another sampling of prepay. So, when a prepay edit is put in, they might say, and remember, these are people that have to look at these claims, so they're going to base it on workload. It's not just a free for all of we're going to look at all your claims. Only in very serious situations will they do that. But they're going to take a selection of those claims, take a look at them, make a judgment on what you're billing and how is it being billed correctly? Is there something wrong? Do you need education in those regulations? They're going to do that, shut off that prepay, and then come back and check it again. Did you improve? Did you not improve? Are you worse? What is the situation? And continue. Now, there is a rule, we generally look at it 3 times, and are you improving or are you not improving? And those can lead to consequences in your Medicare provider enrollment.
Sure. So the important part of that for me is the post audit. So you're on prepay, you get taken off of prepay, and I think sometimes providers get shocked when 6 months or 8 months or sometimes thereafter they get an audit letter that is for precisely the thing that got them on prepay, which they then got off of. And that is really just the basics of any education and training, right? You find the problem, you provide education and training, and then you have to go back at some point later on and identify, did that education and training work? And I think that's for those that are watching this or listening that don't know the TPE program, the Targeted Provider Education Program, that's exactly what that is meant to do, but it's not a prepay. It can lead to a prepay, but you certainly get 2 or 3 bites at the apple. So in the next 15 minutes or so we've got, let's talk a little bit about sort of the error rates that you, in your expert time at the UPIC, what sort of error rates would you typically see that got someone onto a prepay? And then what sort of error rates were you hoping to get after a prepay or after some education to get someone off of a prepay?
Okay, well, so that's leaves me wide open to say a couple of things. One, you might be selected for a prepay and they begin to look at that, what is your error rate? At the UPIC, typically those providers that are under review for a UPIC, they're going to have a much higher error rate based on the data analytics. That would be the expectation than you might see at a prepay at a MAC. And so if you're scoring 100%, there's a problem. If you're scoring, 50% and above, there's a problem. Generally, you're going to be put into these buckets on, is education appropriate? If you're having a very high error rate, it might, lead to something other than education. So depending on where your error rate is, that's going to determine on whether you'll come back and just be educated and put back on prepay or whether there's going to be more serious consequences.
And is it fair to say that in some instances it really is subjective, that there isn't anything hard and fast that says if your error rate is below 10%, you're off prepay, or if your error rate's under 30%, that there really is sort of this totality of circumstances. Is the training and education being ignored? Is it really more of a hard and fast? Once you've gotten below this error rate, you're okay.
So let me give you a little illustrative story. So I worked at the MAC initially, and uh, when we were looking at data, they pulled these providers that they were going to do prepay on, and they were all kind of clustered in a little, it was a scatter plot chart where their error rate was suspected. And, then there's down here below is the general population of people who are billing probably correctly. Little area where the MAC was going to put these providers on prepay. And then way out, in the stratosphere was another dot, and that was when I asked, well, what's that dot way out there? It was for a Z-pick. That was a Z-pick problem. So their error rate is totally in another universe than what the MAC is going to be looking at. So if you're on prepay from a U-pick, your error rate is going to be falling fairly high. If you drop down really low, that you might become still a subject to prepay, but it might be from another contractor. Does that make sense?
Yeah, it does. And I think the difference being is that the UPICs are really looking at the fraud,
Yeah.
whereas the MACs are more of the waste and abuse, which is the loopholes and the weaknesses in the program and things of that sort. I always think about error rates, and the reason I always bring that up is because when you look at a lot of corporate integrity agreements and you look at a lot of the things that are out there from the OIG with respect to corporate integrity agreements, they like to use this 5% threshold that if the error rates are below 5% in some corporate integrity agreement reporting or provider integrity reporting, that it doesn't trigger a reportable event, right? If you have an error rate that's higher than 5%, they sometimes will say that that is a reportable event on your CIA. I know that when we're doing proactive compliance reviews and audits for our provider clients, we're always looking to get those error rates below 5%. We're always looking to find generally an error in the data that is below 5%. And if it's above 5%, is it explainable as an error, as a false positive or an anomaly? Are there other factors that come into play? But that 5% number always seems to be something that is that's out there. And so, everybody that I talk to, when they're always talking about prepays, they're always very curious about whether or not there's a specific metric versus whether or not it's sort of this totality of the facts and circumstances. I always say that when we're looking at a record from a fraud, waste, abuse perspective, it's a lot different than a coding audit where you're just looking at the four corners of the paper and saying, for example, is this E&M documented properly for that code? And from a fraud, waste, abuse perspective, I always think about that sort of that 360 degrees of the documentation. I know oftentimes if a provider is on a prepay or there's an audit going on, for example, for a diagnostic test, the provider's documentation might be absolutely trashed for that particular test on that given day, but there's a whole history with the patient that supports the medical necessity. And so we say to the provider, you're a terrible documenter. However, there's sufficient documentation within the global record, and you just have to learn how to carry that sufficient documentation over to the date of service, because in a review, nobody cares about what you did to the patient so much as they care about how it's documented. I've had so many providers that I talk to will say, well, I document to my treatment. And I say that's phenomenal, as you should, but there's a disconnect between what you're documenting to what you're coding. And that at the end of the day, it's this 360 degree. So talk to us a little bit in the remaining time. When there is a prepay, there's the ability of a provider to submit a lot of documentation, right? It's not just about that particular date of service. What do you see, what would you see in the gambit of that from that perspective, like providers submitting just a single page or providers sending you the baby in the bathwater and saying, here, have at it?
You get both, but there is we call it an ADR, so it stands for additional documentation requested that you're going to get. And usually on that letter, because it's very formatted and it has specific things in all letters, it's going to say submit, and it will run down a list of the items that you should make sure are in that chart. And then you're probably going to see the phrase any and all documentation to support, meaning if there's something extra in there, you better send it. We talk a lot about the quality of documentation. So it's, some providers will send in a huge quantity that will say nothing. And from a medical review perspective, we're looking at what was billed, was it ordered, was it provided as you billed, meaning did it, support that code or that service? Was it medically appropriate or medically necessary, which we could talk a ton about that. And did it fit the benefit category? And then from a UPIC perspective, they go on to say, was there any indicators of fraud, waste, and abuse? So they're not only looking for, provided as billed, was it medically necessary? Did it fit the benefit category? But then they go on to say, is there any evidence of fraud, waste, and abuse?
Right. Yeah, I mean, the example I always like to give is you go to the doctor for a sore throat and the doctor performs an EKG and they document that record from end to end on that EKG, and there's an interpretation, there's a report. It is fully documented, but it's going to get denied, right? Because you went there with a chief complaint of a sore throat. And, I've had providers, try to articulate like something. And at the end of the day, I say, well, the fact that something got paid doesn't mean that the program said it was okay, because this is a must pay sort of, pay and chase environment. And as long as your ICD-10s and your CPTs match, and it's what they call a clean claim, it's going. And I think that's the important piece that you just said is indicators of FWA. And the mere fact that you did an EKG and fully documented it doesn't mean that you've passed the threshold that it's not FWA, that there's that medical necessity piece. And we could have a whole other conversation, as you just said,
Yes.
about medical necessity. But I often will say that there's a difference between medical necessity from the clinical perspective, and there's medical necessity from the documentation perspective, that you can have an EKG that is well documented, and you can say, hey, this is well documented, and the argument is going to be that there was no documentation to support that medical necessity from a documentation perspective. If you felt that the patient needed an EKG, you should have written down what the impetus was for it, not the fact that you did it. There's an interpretation, there's a report, it's date, it's time stamped, you signed it. You did all of the things that would have met the criteria for billing for it. But from a documentation perspective, the words of why the patient needed it are missing, and it's a documentation issue. It's not necessarily a clinical finding, because there's a difference between clinical medical necessity and documentation. And I have this conversation with people about E&Ms all the time, right? No one is saying that you didn't need to see the patient. It's that where is the documentation to say it needed to be here versus here?
Right, right. And we could kind of go on into that conversation. There's so much in that conversation, but a couple of key words that you might think about are when they get a denial that says insufficient information versus this was not medically necessary. And what are the differences in that? And insufficient information might mean that they see the information and that you did it, but there's not enough information to support that why, or there's not enough information maybe that's corroborating those things, meaning there's things that are conflicting in that chart, or maybe conflicting in the billing. Because when you're going through a medical review, they're not only looking at the documentation that you submitted, they have your whole claims history. And so remember, if they're looking at the claims history and that's saying one thing and what they're seeing documented is different, it's that conflict. And really the goal is to make sure that you're paying those claims correctly and that the information supports payment of that claim.
So in the last couple of minutes before we, come to an end, I am curious if you can just talk a little bit about the interaction with a provider with respect to the education and training. I think that oftentimes providers feel, oh, I'm on a prepay, I'm submitting the documentation, it's getting denied. I'm not really told why it's denied. I'm told sort of this in the ether, it doesn't support it, medical necessity and LCD. Let's spend the last couple of minutes talking about that education piece that providers, I think, oftentimes either A, don't take advantage of, or B, don't readily realize exists.
So a couple of key things that if I were on prepay, what would I do? So there are denial codes that you'll see on your claim and you can kind of Google those, and even CMS has a website and it will kind of help give you indications of what either was missing or what category of denial it fell under. Your MACs, your Medicare Administrative Contractors, I would be very familiar with their websites because they have a wealth of information on, different kinds of medical review topics, what they're looking for. Always, always, always be familiar with what are the conditions of payment for that service. Depending on what you're billing, and it could be a whole gamut of things, what are the conditions of payment for a home health claim versus what are the conditions of payment for a lab? And know what that is, because if those items aren't there, it's not going to get, paid. And then, of course, those types of things that fit into that benefit. So you really have to be familiar with what regulation is driving the payment of that claim, and does my documentation support that regulation? Does that help?
Yeah, I mean, sometimes it seems a little bit more straightforward than it is. Oftentimes, we've got some clients who they'll put trigger words into their documentation, and so they'll use a term like screening or something along those lines. When if you looked at the LCD will specifically say that a reason for denial will be that it's not a screening test. And the thing I've said to providers is, I know you didn't mean that. Like, it's not a screening test. You have a patient with a comorbidity. You're doing a carotid Doppler because they've got hypertension, they have diabetes, they have all of these things that make this test not a screening test. But when you use a word like screening, you're immediately negating the medical necessity for it because you've actually identified that service as a screening test, even though that's not what providers have meant. I mean, I've had some instances here where we've got some providers we do some work for who are treating very sick patients who have many comorbidities, social detriments to health, and all of that kind of stuff. And, they go and they get an audit, and it's for a diagnostic test that our auditors come back and say, had you not put this language in, it absolutely would have been covered because the patient's history supports it. There's a medical necessity. So you're hitting it right on the head, right? There's documentation out there. You can always, you always have the ability to look at it. The websites talk about it. And then I think the other piece of the puzzle is that providers have the ability to interface with someone in the provider education department, right? There's an enrollment and there's an education department where providers can call and ask these kinds of questions, right?
Absolutely. So your MAC is going to be your wealth of education. You can call them, you can go on their website. They have what's provider outreach education. They'll come to some of the bigger cities and they'll put on presentations. There are so many ways to get some education, looking at the LCDs, reading those. If you have questions, contacting them, asking those questions. I would, highly encourage looking at that and getting the understanding of what is it that I need to document, and then communicating that to your staff, because your caregivers, your nurses, your physicians, maybe even some of your unlicensed personnel that are touching those patients might not have any idea what a condition of payment is. And yet they're doing some simple, very basic step in that caregiving process that is critical when it comes to payment of that claim. And so it's an education of, we're providing this care, this is what we're doing and how we're doing it. Now let's make sure it all gets documented in a place that gets submitted if a question comes in on payment of that claim.
Yeah, that's great. That's great advice. So it looks like, we're just about out of time. We spent about 30 minutes talking about this. We are going to continue our conversations. We're going to do a few more of these, as you know, Laurie, and we're going to talk in the next couple of weeks. We're going to talk about post-pay, or sometimes what are known as investigational audits. I think it's important that people understand the UPIC doesn't really do an audit in the traditional sense, that these are reviews that are done because there's some indicia or some belief that there's a fraud, waste, abuse, or compliance issue as it relates to the payment of a claim. And so the next I think, sort of piece of this is the post-pay investigational audits, and we'll talk a little bit, how they get there. For me, the biggest thing that I've seen in the prepay world when I was an agent were instances where a provider was on a prepay. One comes to mind, a provider, this is absolutely public record. His name was Shashi Agarwal. He was a cardiologist in New Jersey. He was on a 100% prepay for a number of services. And what he did was he continued to actually render the services on his patients, which he's able to do. And instead of submitting those claims and going through the traditional prepay process, what he did was he turned over the records for those tests that he did to a friend of his who owned an independent diagnostic testing facility and had those claims submitted under his friend's NPI number. So his friend who had the IDTF was reimbursed for the services as if the IDTF rendered them, but they were really rendered by Shashi Agarwal. All that he was doing was circumventing the prepay. What ultimately got him caught was I had an investigation involving the IDTF. I saw that a lot of the claims were coming in with Shashi as the referring, and when we subpoenaed the IDTF, they were kind enough to actually send us all of the records in which the IDTF's name wasn't on a single document. There was a prescription or an order from Shashi Agarwal. The tests were done in his office on his equipment with his technicians and his staff. And the reimbursement was going to the NPI, and then we could see that there was a flow of money that went. So, circumventing an audit is a problem. It can lead to criminal charges. It is common. You see in the press releases all the time about providers who were under prepay and created a shell company or did something to kind of circumvent that. So, it's an important piece of the fraud, waste, abuse continuum. It's an important piece of how the program polices providers who do not wish to be compliant or are failing to be compliant, whether by intent or through the waste abuse part. So great conversation, Laurie. As always, I always tell you this, but we're super happy to have you here with us here at Advize. The work you're doing is great work. Your knowledge is really deep. Every time you and I speak, I pick up another little nugget of information about something. I look forward to talking to you again on the post-pay or on the investigative audits. At the end of the podcast, we'll put up how people can get a hold of us to talk to us about things like lunch and learns and, just some of our general outreach that we do to the provider and the payer community. Any final thoughts, Laurie?
Oh, thank you for allowing me this opportunity, Eric. I really appreciate it. And of course, I always have tons to say about getting those claims paid, getting them paid correctly, and following the rules that help you get paid in an efficient manner and the right amount for the right service that you do. And I would love to speak on all of those topics.
Awesome. Well, thanks everybody again for tuning in. Again, I'm Eric Rubenstein. I'm the Director of Litigation, Fraud, Waste, and Abuse Support here at Advize Health. And until next time, we'll see you.